All right, so chapter 4 continued. We're going to talk about membranes. We did mention membranes in chapter 1, but the reason that we kind of talk about them in chapter 4 again is because they are a combination of connective tissue and epithelial tissue. You've got this thin sheet or layer of tissue that basically covers not only the structure, but lines the cavity that structure is sitting in. So we actually have several types of membranes. We've got one external membrane, and we have several internal. Our external membrane is pretty easy to spot. It's the skin. We only have one. It's there, and it is a membrane because it does separate our body from the rest of the world. Internally, we have three different kinds. We have mucous membrane, serous membrane, and synovial membrane. Physiologically, mucous membranes, functionally, what they're doing is they're protecting, they can absorb, and they can secrete. So where would you find them? Mucous membranes are the linings to things that open to the outside world. So this would be the nose, the mouth, the digestive tract, all the way to the anus, because it opens to the outside world. The tube going up to our bladder is technically a mucous membrane because it is a potential way for things to get into our body. The serous membranes, physiologically, they are there to protect our organs from rubbing up against each other, and they're kind of like suspension bridges or suspension lines on a suspension bridge in the fact that they also help to hold things in place. Because they are lining our internal organs, they also provide a barrier for the organ that they're on top of. They prevent fluid accumulation and things like that. So serous membranes line the cavities that are not exposed to the outside world. So if I were to say, okay, where would this be? I can't touch my heart. Even coming from the outside in, I can't, there's no tube anywhere in my body that would be able to lead to where my heart is. So my heart and where it sits in its little cavity, in its pericardial cavity, is a serous membrane. My lungs, it's the outside of my lungs, it's the same thing. That part of my body doesn't touch the outside world. Now, the air going into my lungs is a bit different, but the surface of my lungs don't touch anything. It's kind of like saying the air in a balloon. The air in the balloon doesn't touch the outside of the balloon. It stays inside. So that's serous. And in the picture, serous is going to be this light blue, okay? Synovial. So synovial should become synonymous with like your knee. It's joints, okay? They produce a fluid called synovial fluid. It's rich in the hyaluronic acid that we talked about before, the one that acts as a lubricant, and it actually facilitates the smooth movement of our joints. So any freely mobile joint, anything that you can bend and twist and do, all of them will have this synovial membrane, creating synovial fluid to make lubricant so that your bones don't rub each other. Well, actually, your cartilage doesn't rub each other. Inflammation. Inflammation is a reaction in the body that occurs when you've got tissue damage, and it is associated with your body's immune response. So, inflammation has 5 major manifestations. Everybody's probably played either the Indian burn game or the game where you lick your fingers and then whack somebody's forearm as hard as you possibly can, right? When you were a kid. Don't judge me. So, when you've got actual inflammation, there are 5 things that you're going to see. You're going to see redness, That finger licking game, you see the 2 fingerprints on the person's forearm, you're going to feel heat. You know, when you injure yourself and you go to your mom and go, it has fever, mom, it has fever. Okay. There's going to be swelling depending on how bad the injury is. Of course, there's going to be pain. And depending, like I said, on how bad it is, there could be disturbance of function. There's a difference between the Indian burn game and the, slapping your fingers game versus I broke my ankle. Okay. If I break my ankle, it's not like I'm going to be getting up and moving around. Okay. So, what does inflammation do? Well, one, it mobilizes your body's defenses. Something's been damaged. I need to get my army there to make sure that everything's okay. It also tends to isolate that damage so that, let's say it's a puncture wound, hopefully nothing from that area where the dirty puncture happened actually spreads anywhere else. It destroys the microorganisms. If there are invaders that have infiltrated your body, they're going to try and kill them before they can go anywhere else. And it gets rid of the other injurious agents. Again, let's say there's dirt on whatever punctured my skin. Those are injurious agents. They could be carrying other things with them. So yeah, it's going to take care of all of that. It removes foreign materials and damaged cells, so tissue repair can happen. So something I think a lot of people don't think about is if there is damage to your body, there has to be cleanup before I can fix it. Think about it this way. Let's say I say, I'm going to build a whole new CBC and I tear down the buildings. Well, if I tear down the buildings, I've got to get all of that garbage out of the way before I can build new buildings, right? So that is this. When you damage cells in your body, there are cell bitlets and chunks and all kinds of stuff everywhere. You have to clean that out before you can build new and repair the damage that's been done. So, in an injury, you've got chemical mediators. Mediate just means control. Chemical controllers that are going to be released, and they activate in the tissues. Basically, they help to activate adjacent blood vessels as well, the ones that are right next to the injury. These chemicals can include things like histamine and kinins and prostaglandins and leukotrienes. It can induce blood vessel dilation where the blood vessels kind of become a little bit more holy. And that means that the area becomes more red because the blood is flooding out to that area. And because the blood is usually warmer, it also heats that area. The benefit of doing this, making bigger doorways in that blood vessel, is that white blood cells have an easier time getting there. I don't have to try and wiggle through it. If it's leaky, I can just go and I'm there. I'm first responder. Some of the chemicals that I'm talking about will stimulate pain receptors. Some will increase blood vessel permeability, like I said. That will also allow clotting proteins and white blood cells to move into that blood vessel. Okay. So if I'm bleeding, I need to stop the bleeding. This actually facilitates those chemicals that will help me to do that, to get there and get activated. Okay, proteins will also move into the tissue. If I put salt in your mouth, what are you going to ask for? Water, right? Thing about moving the proteins is that water follows it, kind of like me putting salt in your mouth. That can actually cause swelling. Now, this is the thing with swelling. Swelling increases the pressure on the tissue, and it can actually stimulate pain receptors. When you got, an injury and it swells up, it can actually basically hit the nerves, sending pain signals to your brain going, okay, this hurts, this hurts, this hurts, because the nerves are basically getting pinched. Clotting proteins also help to isolate the injurious agents. The last thing I want is if something invaded my body, for it to get into my bloodstream and go to a secondary location. No. Let me, clot where this is, and then it stays right where it's at. Pain and edema. Edema is a fancy way of saying swelling. Depending on the injury, it can cause disruption of function. Thus, the person is going to be careful with the injured area and prevent further damage. Meds can be given to manage the symptoms, and in some cases, depending on if there's an infection, antibiotics can be given. But there needs to be a balance. One of the biggest issues with professional athletes is they will get injured, and rather than take the time to get better, they say, give me a pop of pain medication and I'll go back out there. And they keep going. Problem. You're injuring yourself worse. There is a reason we feel pain. We feel pain so that we don't do those things, so that we give the area enough time to heal. When we don't feel pain, we don't know that there's anything wrong. When we feel pain, we tend to be tender with things so that we're not kind of overdoing it. So in the picture, I've gotten a splinter, okay? It comes in, and look at all those little green things. I've got these little foreign invaders coming into my body. You'll notice that redness is already starting, the swelling is already starting, and my blood vessels have become leaky. You can see that there's kind of emptying of this, which means that here are my white blood cells. Hopefully they can get out there a lot faster. Here are my bacteria that are invading through that splinter. Here are my white blood cells going to eat them. No, you don't get to come in here. This is my house, okay? And again, comparing the pictures, there's a little bit of swelling here. There's a lot of bit of swelling there because these have been leaking for longer, okay? There we go. So what about repair? Tissue repair is basically substituting living for dead cells. That's ultimately what we're talking about. But it can happen in two ways. You've got regeneration and you've got replacement. Regeneration means that new cells are being provided, but they're the same cells that died. Okay? So we're replacing what we lost with the exact same thing. Normal function is usually restored when regeneration happens. Replacement is different. Replacement means that we are going to put a new type of tissue. We're not going to put the same thing back. We're going to put something like scar tissue back. And depending on how bad the injury is, with scar tissue, sometimes you don't get function restored. Which path it takes depends on which tissue is involved. And that has to do with these cell classifications down here. Labile cells. Labile cells are cells that basically continue to divide throughout your life. Your skin is a real good example of this. Your skin grows all the time. Every single second of every single day, you are making new skin. That's why I can, trip and skin my knee and it heals and I still have skin there. Okay? Stable cells. Stable cells don't divide after we stop growing normally. Basically, you get to a certain stage in life and it goes, okay, I'm done. But with stable cells, they do retain the ability to divide. It's just that they won't unless you push it. So a good example of that would be the liver. The liver, once it's grown into your liver and you have it and it's functioning, it just stays that way. It doesn't get bigger. But let's say that I need a liver transplant and you are a tissue match to me. Well, I can take half your liver and you can keep half your liver, and your liver will grow back into a full liver, and the piece that you gave me will grow into a full new liver. If you push it, it will grow, but it doesn't do it normally. That's stable. Permanent cells. Permanent cells are not the same thing. They have very limited regeneration. If they're killed, usually they're going to be replaced by something different. The kind of dogma of biology is that neurons are like this. If you kill a neuron, it's gone forever. It's not going to come back. You can reroute things And like stroke victims can have, the wiring kind of rerouted so that they're doing better, but what died is never going to come back. So, tissue repair, you've got primary versus secondary union or intention. Um, a primary union is kind of like a paper cut, okay? The edges of the wound are close together and they're very, very smooth. It's very easy to kind of seal that kind of wound up. A secondary union is a bit different because it means that you've basically taken a chunk out of somebody. So the edges of the wound are going to be further apart. You're going to have loss of tissue. It's not just a slice in that case. So in a primary union, the wound would fill with blood. You'd have a clot form with fibrin. And the fibrin, notice the name, fibrin, is fibers that bind the edges of the wound together. It's almost like it seals the wound, okay? The clot surface dries, it forms a scab that seals the wound. That actually helps to prevent infection. It's like putting a cap over a hole, okay? In the inflammatory response that happens, you're going to get the vasodilation. The vessels are going to kind of dilate and allow them to leak. That means you increase the blood cell number and other substances into that injury area, the edema that we saw in that picture. The blood vessel permeability goes up. It causes edema, swelling. Fibrin and blood cells move to that injured area. It acts as a blockage. Basically, I'm blocking access to the rest of the body by causing a clot to form right there. White blood cells, the neutrophils, will start to eat the bacteria. They'll eat the debris and they clear the area for repair. Remember what I said, if I'm going to fix it, I've got to actually clean up first. Pus, when you see pus in a wound, usually it's dead neutrophils and fluid. If it is clear like water, that's exactly what it is. If it is kind of yellow or green, you probably have some bacteria in there as well. So the fibroblast, remember blast meant to build. So what are we building if we're fibroblasts? Fibers, good. From the surrounding connective tissue come in. They migrate to the clot area and they start making the extracellular matrix components. Remember, extracellular matrix is everywhere, but I'm going to start making the collagen fibers and the elastic fibers and all of those. The capillaries grow from the blood vessels at the ends of the wound and they revascularize. If I've actually damaged blood vessels, I've got to grow those things back together. The fibrin in the clot breaks down. Once I've sealed those blood vessels, I don't need that clot there anymore. So you've got this clot being replaced with a delicate connective tissue called granulation tissue. Granulation tissue is a combination of the fibroblasts, collagen, and capillaries that are just kind of growing to fill that space. Eventually, that granulation tissue will become a scar. Now, scar tissue is different than the regular tissue. This isn't this isn't regeneration, this is replacement. So scar tissue is dense, irregular, collagenous connective tissue. So it's not the same thing. When you do end up with a scar, it usually appears red, and that's because of that new vascularization, the new blood vessel formation. The white blood cells and the collagen accumulating there also tends to compress that vasculature, making it kind of seem like, wow, that's really, really red. Now, in a secondary union, remember, this is where a chunk has been taken out. It's not a paper cut anymore. There's a large distance between the two halves of the wound, which means the clot may not actually pull the ends of the wound together. There may be a gap in there. The problem with a secondary union, it's going to take longer for the cells to regenerate. It's going to take longer to cover the wound. Why? You've got increased tissue damage because I didn't just do a paper cut, I actually took a chunk of tissue out. You've got increased inflammation because there's a larger area involved. There's going to be an increased number of cell debris to clean up, again, because the hole is bigger. And with that comes an increased risk of infection. So more granulation tissue development happens. You end up with wound contraction sometimes. If you've ever had a scab and it kind of gets that scallopy edge to the end of it, yeah, that's contraction. That's wound contraction. Those fibers are still trying to bring the edges of the wound together, but if it's too far apart, it can't do it. Now, depending on how bad this injury is, if it's really truly bad, this can be disfiguring or it can be debilitating. If your scar, if that hole is so big that your skin starts to yank on you, it can actually make it so that it doesn't work at all. Doctors will actually suture wounds, big wounds like that, closed. And it's a way to kind of trick the body into thinking that this is a primary union with the two halves of the wound right next to each other. The other thing that this does is it reduces the chance of infection because I'm not leaving a gaping wide hole open. It also helps to reduce scarring because I'm not producing as much scar tissue because the edges of the wounds are closer together. So, looking again, I've removed the splinter. You can see the blood coming up into this space here. Fresh wound through the epithelium, and a clot is forming. Now, about a week after my wound, after my injury, okay, about a week after that, there it is, okay. You can see that there's a scab present. I also want you to notice that the skin has actually started growing down into the wound. Do you see that? It's actually coming down here, okay? That is about protection. Your skin is protective, right? So having the skin kind of go under that scab is actually gonna help with that protection. As we start to heal, granulation tissue starts to kind of replace that hole that's down here in number 2. Again, you got fibroblasts, you've got the other types of cells that are there. The scab is getting a little bit smaller, and now you can see that skin is all the way below this scab here, okay? It's not just on the sides anymore. After about a month, you've got quite a bit of granulation tissue, but you've got freshly healed epidermis too, okay? So, tissues and aging. I will say this at the end of every chapter with an organ system aging slide. Everything goes downhill as we age. Age-related changes result from the rate of cell division, the changes to the extracellular fibers as well. As we get older, we don't make as many cells as we used to. And the fibers, the collagen fibers and the elastic fibers and the reticular fibers that we're making aren't the best quality either. So the collagen that we're making actually becomes less flexible. And what that means is it's not as strong. If you've ever been around somebody who's geriatric, you can hit the corner of the table with your arm and it's not that big of a deal. If you've got somebody in their 80s or their 90s and they hit the corner of a table, their skin tears like it's tissue paper. And it really does have to do with the fact that their collagen just isn't as strong as it used to be. The elastic tissues will start to become fragmented and less elastic. If you've ever seen, again, somebody older, their skin doesn't have that bounce back that younger people's skin has. So again, as we age, things just don't work as well anymore. And that's the end of chapter 4, which is the end of unit 1. So don't forget that your exam is going to include chapters 1 through 4.